Welcome. I'm delighted that you can all join us for our second presentation in the 2025 OLLI at the U Lecture Series. I'm Laura Peterson, an OLLI volunteer. The OLLI Lifelong Learning Institute at the University of Minnesota is a vibrant learning community for people aged 50 plus. Part of the College of Continuing and Professional Studies, OLLI belongs to a national network of Osher Lifelong Learning Institutes supported by the Bernard Osher Foundation. I'd like to acknowledge and say thank you to our sponsor, the University of Minnesota Alumni Association. We acknowledge that the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. It is important to acknowledge the peoples on whose land we live, learn, and work as we seek to improve and strengthen our relations with our tribal nations. Today's lecture is titled Identifying and Seeking Solutions to Rural Health Issues. Our speaker is Dr. Carrie Henning-Smith. Dr. Henning-Smith is an associate professor in the Division of Health Policy and Management at the University of Minnesota's School of Public Health. She has 3 master's degrees in social work, public health, and health services research, and received her PhD in health services research from the University of Minnesota. In addition, she's the co-director of the Rural Health Research Center and the Rural Health Program, and has been a University of Minnesota McKnight Presidential Fellow for the last 3 years. I will open the floor to you, Dr. Henning-Smith.
Thank you so much, Laura. I am delighted to be here with all of you today to talk about the work that I do at the Rural Health Research Center and the Rural Health Program. I'm going to share my slides here and get them in presentation mode for you. Okay, I was asked to come today to talk about what's happening at the University of Minnesota around rural health and also to provide some general updates on rural health issues. So I'm going to do my best to do those things, knowing that I'm just going to scratch the surface. There's a lot to say, and there's a lot happening across the University of Minnesota system on rural health. I'm going to be focusing today on the work that we do at the Rural Health Research Center and the Rural Health Program, but I want to acknowledge all of my colleagues across the university who are doing really incredible work in this space, and maybe we can talk more about that in discussion later. Here's a quick agenda of where I'm headed for the next 50 minutes or so. I'm going to provide some background on rural health so that we can all get on the same page on why this is important. I'm guessing that you already believe that it is, and that's why you're here. But if you need to be convinced, hopefully I'll be able to convince you. And then I'm going to talk to you about the University of Minnesota Rural Health Research Center and Rural Health Program. And I'm going to give you a couple of snapshots of recent research projects and ongoing research projects that we've been doing at the Rural Health Research Center, one on the rural health workforce in Minnesota and one on rural medical debt. So that's where we're headed. And before we go there, I want to start by grounding us from a strengths-based perspective. Often when we talk about rural, we talk about it from a deficits point of view, and you're going to see some meaningful deficits reflected in some of the health outcomes and issues that I'm going to talk about today. But it's really important to acknowledge that rural areas are so much more than any deficits that we might talk about. Rural places are really, in every way, the middle of everywhere. I'm not a fan of the middle of nowhere expression. I like to think of the middle of everywhere. Rural places make up the vast majority of land area in the United States. Depending on how we're measuring rural, we're talking up to 95% of all places in the United States are rural. And rural places are sources of energy and food and natural resources and beauty and recreation and community. They're home to 60 million Americans. They are vitally important to everything about our lives. Even if you spend your entire life in an urban area, you are intricately connected with rural areas, with rural people and rural places. So I want to start with that grounding and acknowledge that I am going to talk about some challenges and some structural issues that I think need addressing. I also want to start by positioning myself in this work and my own investment and interest in this work. I was born in rural Kansas and spent most of my childhood and growing up in rural southern Wisconsin. But when I think about rural, the place that holds particular meaning for me is Mendota, Illinois, the home of my grandmother for most of her life. This is my grandmother holding me as a baby in the early 80s. She spent her childhood and most of her adulthood in Mendota, Illinois. She had incredible community there. She was deeply invested as a teacher, a librarian, a volunteer, a member of her faith community, a friend, a family member, a community member. She really was deeply tied to this community in a way that I saw reflected every time I went and spent time with her. She also, I think, died too young. She died very suddenly when I was in high school, and she died because she didn't have access to the care that she needed, the life-saving care that she needed. In her community, she ended up needing to be flight for life lifted to Mayo Clinic in Rochester and died on the operating table there. And I think about her in all of the rural health work that I do. I wish that I had had many more years with her. And I know that her story is not unique. Her story extends to many people who don't have access to the timely and high quality care that they need. And if I can do something to prevent someone else's grandmother from dying too soon, I will gladly devote my work to that. So when I say rural, I want to be clear what I'm talking about. And I'm going to be clear in that I'm not being entirely clear. There are many, many ways to define rural. In policy, in research, we define rural using a variety of metrics. Sometimes we're talking about counties, sometimes census tract, zip code. Sometimes we're talking about population density, how close people live together, and how many people there are per square mile. Sometimes we're talking about commuting patterns and how closely a sparsely populated area is connected with the economic activity of a more urban area. Sometimes we're talking about how far or close a place is to an urban area. And sometimes we simply ask people to identify, do you live in a rural area or an urban area or a suburban area, and let them identify what that means for themselves. I'm not going to get into what all of these different definitions mean. That would be a different lecture for a different day, and it's something that you could spend your entire career studying, and some people do. But I just want to name this. There are many ways to define it, and when you see reports about rural, it's worth asking the question how they're defining it, what they mean when they say rural. It's also really important from a policy standpoint. There are different definitions set out by different governing agencies, and those definitions mean that people are or are not eligible for rural-specific funding and rural-specific policies and regulations, depending on which definition is used and whether or not they fit into it. And if this is something that's interesting to you, if I can give you one nugget today that you might find useful, this might be the best nugget I can give you. The Rural Health Information Hub is a federally funded website that's meant to provide useful information to rural community members or anyone interested in rural health issues. And I have to uh, give the caveat that I am an advisory board member of RHI Hub and perhaps its biggest fan. So I'll acknowledge that conflict of interest here, but also want to leave you with this tool. You can go on to RHI Hub and their MI Rural tool. If you're curious, you can put in any town, village, county, census tract, zip code, and then run the report to find out if it qualifies as rural under any of the different definitions that are federally recognized. So here I put in Mendota, Illinois, home of my grandmother, who I introduced you to earlier. Then I click Run Report, and I get this report here. It gives a handy map of where the community is that I'm looking at. and then lets me know whether or not this community is eligible for grant programs from the Federal Office of Rural Health Policy, whether it's eligible for grant programs through the Centers for Medicare and Medicaid Services Rural Health Clinics program. And it runs through the different federally recognized definitions of rural that are used by different agencies, by Health and Human Services, by USDA, and others. And it lets me know how this community is classified across each of these different definitions. I'm not going to go through all of these, but RHI Hub offers really nice tools to define each of these different measurements. If you're interested, you can go into that in your spare time and play around with it. I think it's really fun. I have my students in my rural health class that I teach spend time with this tool. I think it's incredibly useful for rural health activities. So why focus on rural health? I have devoted my career to focusing on rural health. Why do that? Why not just focus on health generally? Health generally is certainly important, and there are no shortage of health issues in urban areas too. But the reason to focus specifically on health within rural areas and to separate rural areas out from urban and suburban areas is because rural areas are qualitatively different. They are different than urban and suburban areas when it comes to demographics, socioeconomic and industry landscape, infrastructure, health outcomes, healthcare access and quality, and so much more. I'm going to run through each of these briefly just to try and convince you of these points. First, for demographics, rural areas on average overall are more sparsely populated, meaning there are fewer people and the people who do live there live farther apart from one another. And overall, for the entire country, rural areas have been losing population for several decades now. There's a lot to be said about losing population, and sometimes, again, this is really framed as a deficits standpoint. I want to name that there are plenty of rural communities that are gaining population, and we see rural communities that are growing. And in some cases, rural communities grow enough that they become reclassified as urban communities. So because of that, our overall rural population has gotten smaller, but it's not always because people have moved out of rural places. Sometimes they've lived in the same home, the same community for their entire life, and wake up one day to find out that now they live in an urban community. So again, meaningful to interrogate the different definitions that we're using and think about what it means when we're saying that they're losing population. Rural areas are also older on average than urban areas, which I think brings up a variety of exciting opportunities and also specific needs around services and accessibility and making sure that we have thriving communities for everyone. And rural communities are changing racially and ethnically. They're increasing in diversity. And to be clear, rural communities have always been racially and ethnically diverse, but we're seeing that increase in recent years. And I want to give you an example of how some of this comes together. This graph shows population change in rural areas between the 2010 census and the 2020 census. The blue lines are where we've had growth in population, and the red lines are where we've seen a decrease in population. What's important to take away from this is that international migration, so international immigrants into rural communities, were a bigger factor for rural population growth than birth by a factor of almost 2 to 1 during this period. And if it weren't for international immigration, that net population change that you see on the right-hand side would have been much steeper. International immigration is really important to our thriving rural communities and presents a variety of opportunities for us to think about how communities are welcoming, open, accessible, thriving, and culturally diverse. Rural areas also differ from urban areas in terms of the industries and occupations that people work in and the economics of those communities. On average, rural areas have higher poverty rates and lower median incomes than urban areas and lower educational attainment. There are lots of reasons for this. Sometimes it's simply barriers to educational attainment in one's community that requires people to move out. And once people move out, they don't always move back. There aren't always jobs available for them to come back to. We've also seen that rural areas have slower job growth and had slower economic recovery from the last recession. And rural areas have different distribution of jobs and industries. That doesn't mean that rural areas are entirely different from urban areas in terms of their jobs and industries. Some of the most common jobs are the same. A lot of people working in government, education, healthcare, and social services. But in rural areas, we also see jobs around agriculture and manufacturing and mining and food production, meat packing in rates that we simply don't see in urban areas for reasons that are probably pretty common sense, but really important to the way that communities work and thrive. And then rural areas are different than urban. And in terms of infrastructure, I am guessing some of you are calling in from rural areas, and perhaps you have struggled at some point with access to broadband internet or cellular connectivity. Perhaps you're calling in from an urban area, but you've traveled to rural areas or through rural areas, and that's something that you have experienced yourself. That's gotten better. We've had investments in infrastructure that have made a meaningful difference in technology and not technological connectivity, but we still have a long way to go to make sure that everyone has access to the same sort of accessible technology. Rural areas also have persistent transportation challenges. This is simply because it's a more complicated picture to move people from point A to point B when people live farther apart, when people live farther from services, and when there isn't the population density and the tax base to support the types of public transportation that we have in many urban areas. Many rural places do have public transportation, but it tends to be more limited, fixed routes that run on a more limited schedule. And rural areas have older housing stock than urban areas, which represents a variety of challenges and opportunities when it comes to accessibility and the need for maintenance, repair, and modifications. And then the focus of my work is on rural health. And so I want to spend a little more time here talking about rural health outcomes and how rural and urban places differ when it comes to health and health outcomes. This, by and large, is not a good news story for rural. And so I want to acknowledge that, and I want to think of ways to address that. And I will talk about some of the things we're doing later to address that. But first, just grounding us in some of the data. People in rural areas have, on average, lower life expectancy, higher disability rates, higher rates of just about every chronic condition, with the exception of asthma, higher rates of suicide and other mental health conditions, and within rural areas, poor outcomes for nearly every demographic group. And so if you were to look just by a specific racial or ethnic group or age or gender or whatever group you want to look at, you're going to find that the rates are poorer among rural adults or rural individuals than they are among urban within that specific group. And there's quite a bit of intersectionality that we see happening where some of the poorest outcomes are for people who experience structural disadvantage by virtue of their demographic group and their rurality. I'll give you some examples of this here. First, maternal mortality. I probably don't have to tell any of you that we have a crisis when it comes to maternal health and maternal mortality in this country. Our rates are far worse than most of our peer countries. Really a source of great shame and a place that requires quite a bit of attention. But where this is most striking and most concerning is in the most rural places. can see here that there are three types of urban counties that are broken out on the left: large metro, medium metro, and small metro. Those are our most and least populated rural or urban areas. And then on the right, those two bars are rural places. Micropolitan counties, generally speaking, have populations between 10,000 and 50,000. Non-core rural counties, generally speaking, have populations of less than 10,000, or you won't find any community in those counties with 10,000 people or more. Those non-core rural counties have the highest rates of maternal mortality, a difference of almost 10 maternal deaths per 100,000 live births between non-core rural counties and large metro urban counties. This requires immediate attention. We do a lot of work at our center on this, and there's a lot of work happening across the country to try to rectify this, and there's still a long way to go. It's not just maternal mortality, though. Premature death overall is much higher in rural places than it is in urban. This chart shows premature death, that is the age-adjusted mortality rate per 100,000 people. This is a way that we like to look at death in epidemiology. And it shows it from 1999 through 2019, so a period of 24 years, or 20 years, that notably happened right before the COVID pandemic. What I'll tell you about that is that COVID exacerbated the inequities that I'm showing you here, made it worse. There was a decline in premature death across the country during this period, but we saw that decline most slowly in rural areas, and in some years it plateaued entirely in rural areas or even ticked up slightly. Rural is that darkest bar on the top. And this slide, I know, is really hard to read. You don't need to read all the details on this slide, but what I want you to take away from this is that for each of the 5 leading causes of death in the United States, which are unintentional injury, chronic lower respiratory disease, including COPD and emphysema, heart disease, stroke, and cancer, rural counties have the highest rates of death for each of those causes, and that's been true for many years. And in the cases of some of these, especially cancer, we've seen those inequities widen over time. There are many reasons for the health inequities that I showed you. Healthcare is just one piece of that. It's not the whole piece. The social determinants of health and our built environment, our environmental exposures, and our health behaviors play a large role. But healthcare access is an important part of it, especially when you need the type of timely emergency care that my grandmother needed, or especially when you need preventive care to stave off the emergency that my grandmother had in the first place. And so I want to run you through some structural inequities that we see between rural and urban places when it comes to healthcare specifically. Rural residents have higher rates of being uninsured compared with urban. Rural residents also have higher rates of using Medicaid across the board. Rural residents have higher enrollment in Medicaid, which makes me particularly interested in and concerned about potential cuts to Medicaid and the impacts on rural populations. Rural areas also have fewer healthcare facilities and fewer providers per capita. This is particularly an issue if you need specialty care. Think about the example of cancer that I showed you. If you need oncology services and don't have those in your local community, it can be incredibly difficult to access those if that means needing to travel, if that means needing to take time off of work, find childcare, find caregiving, find transportation. All of these issues compound. And rural rates have much higher rates of medically underserved areas and health professional shortage areas. These are both designations that are used at the federal level to identify those places that are least well served by healthcare and by health providers. Approximately 70%, more than 2/3 of all health professional shortage areas are in completely or partially rural areas. I'm going to give you a few pictures here to try to emphasize the point that healthcare access in rural places can be challenging. You may have heard about rural hospital closures. This has gotten a lot of media attention and has been an ongoing challenge for at least the past 2 decades, but I would argue even before that. This slide here is a slide that was produced by my colleagues at the University of North Carolina. They look at where rural hospitals have closed, and every one of those blue dots represents a rural hospital that has closed in the past 20 years. The two yellow dots that you see are rural hospitals that have closed in 2025, this year. This is an ongoing challenge. This is a current challenge. Probably not lost on you that we have several dots here in Minnesota. In some cases, when rural hospitals close, they're able to convert. There's a new program called the Rural Emergency Hospital, where a hospital can convert to a freestanding emergency room to try and stave off the worst losses of losing one's community hospital. But I would argue that having an emergency room in your community is not necessarily a good stand-in for having an entire hospital where you can receive outpatient and inpatient services, which makes me deeply concerned for the communities that light up in blue here. I think it's also worth pointing out that the geographic distribution of where these hospitals have closed is not random. You can see that the Southeast has been particularly impacted. One factor among many that's associated with rural hospital closures is whether or not a state has expanded their Medicaid program. As I've said, rural residents use Medicaid at a higher rate than urban residents. And when states haven't expanded Medicaid, it means that the hospitals in those communities are providing more uncompensated care, and that can make it hard for them to balance their bottom line and keep their doors open. There are many other factors that go into these rural hospital closures. It's not only that, but I do want to lift that up, and I'm happy to talk more about that in the discussion later if you'd like. It's not just hospitals, though. I think hospitals have gotten the most attention in media and in policy, but there are a variety of other healthcare facilities and healthcare service lines that have lost, that our rural residents are losing access to over time. This graph is from my colleagues at the Rupri Center for Rural Health Policy Analysis out of the University of Iowa. This shows rural pharmacy closures or pharmacy closures in urban places as well, but I want to highlight the rural ones. You can see a percent change in retail pharmacies of between 2003 and 2021 here. Metropolitan urban places are that dotted blue line on top, and they have mostly gained pharmacies. They've had a few years where they've lost a little bit, but they're mostly gaining pharmacies and looking okay. The story is not the same for rural places, and especially for non-core rural counties where we have seen a decline in the availability of retail pharmacies over time. Certainly, there are alternatives to retail pharmacies. Some people get their prescriptions by mail. And yet, I think for many people, if you don't have access to a pharmacist or someone to talk to in person, if you have questions, if you have complicated medications, or even new prescriptions that you need to take, I think that there's a loss here, and a loss that particularly impacts rural residents. At the University of Minnesota Rural Health Research Center, we have invested many, many years in studying obstetric unit closures in rural areas. This is another rural service line loss that has gotten a lot of media and policy attention, and maybe you've seen some of that. This graph shows the percentage of rural micropolitan in yellow and rural non-core counties in maroon that have hospital-based obstetric services, and the change in that percentage from 2010 to 2022. I want to draw your attention to that bottom right dot there, where we see that fewer than a quarter of rural non-core counties have a hospital that has an obstetric unit in which you can give birth. We've done other work at the Rural Health Research Center showing that if a county loses their hospital-based obstetric service, that means that there is a higher rate of people giving birth outside of the hospital. Sometimes that might be a planned home birth or in a birth center, but sometimes that's a birth on the side of a road or in an ambulance or a less than ideal setting. We've also seen that there's an uptick in people giving birth in hospitals without obstetric units, which almost always means giving birth in the emergency room. And those of you who, like me, have given birth before, you can imagine that giving birth in an emergency room is not the ideal setting. It's not what most people would want to or plan to do. We've also seen an increase in preterm birth and low birth weight among those counties that have lost their obstetric unit. And then this chart shows where counties do not have nursing homes. I mentioned that rural counties have more older adults. Certainly not all older adults need nursing homes, and not all nursing home residents are older adults. And yet, where you have counties with higher populations of older adults, it's important to make sure that there's a robust system of long-term services and supports. And we have many counties where that's not the case. On this map, the rural counties or non-metropolitan counties are those in the kind of mustardy brown color. And then metropolitan or urban counties without a nursing home are in the bluish teal color. You can see that many more rural counties do not have a nursing home here. This again is from my colleagues at RUPRI, and they've also done analyses to show that we've had loss of nursing homes across the country in recent years, and that loss has been much steeper in rural counties. I've done work at our University of Minnesota Rural Health Research Center to understand what barriers are to nursing home care access for rural residents. And in part of that work, I was able to interview hospital discharge planners who were trying to place people within nursing homes, and found that there are heartbreaking stories from around the country. One that sticks with me is a hospital discharge planner in Idaho. You can see that Idaho has many counties without nursing homes, who had to place someone 9 hours from their home, from their community, to receive the care that they needed. And that just sticks with me. Think about the impact not only on that individual, but on their spouse, on their family, on their loved ones, and on their community. Before I move on to talking about what we're doing here at the University of Minnesota, I want to leave you with a few overarching points. I spent a lot of time talking about rural health and rural healthcare access. And in doing so, I may have suggested that rural is one big homogenous group, and it's not. Rural areas are not monolithic by any stretch of the imagination. By every measure we could use to look at diversity, rural areas are diverse. Here's just one measure, and that's looking at the majority racial or ethnic group within a county. This is from a paper that I published in 2019. And so if we were to do this again today, you would see even more color in this map. But to walk you through this, the gray counties are urban counties. And so I wasn't looking at them in this analysis. But all the rest of the counties in the various colors are rural. So again, to make the point that rural places are the majority of land mass in the United States. And those counties in the light teal color are majority white counties, but all of the other counties represent places where the majority racial or ethnic group is Black in the case of the red counties, Hispanic in the case of the mustard yellow counties, American Indian or Alaska Native in the case of those darker teal counties, and where there's no majority group, where there's a real mix of different racial or ethnic groups, and none of them have more than 50% in the green counties. As I said, we've had increasing diversity over time and in recent years. And so again, there's been even more counties that would be switching colors here if we were to use the latest census data. But I just want to leave you with the point that rural counties are incredibly diverse across every measure. They're also diverse economically speaking. They're diverse in their topography and their access to resources, in what they look like, what they feel like, in their size. And so please don't leave with the assumption that they're all the same. They're certainly not. And I'm guessing that you know that and have lived experience in that among many of you yourselves. I also want to show this chart. If you haven't seen this before, I think this is a really helpful reminder of where we've been as a country since about the start of the United States. This chart just goes back to 1790, so we started a little bit before that, but this gives you the point. When the United States was first founded, we were mostly rural. That was the norm. To live in an urban area was really fairly unusual. Urban is the blue part in this graph, and rural is the green. We're in a very different place today where rural makes up a small minority of the population. Because of that, the attention to rural places has changed over time. The power and influence and voice that rural places has changed over time, and the way we think about and understand rural areas has changed over time. I have a minor in demography and could sit and look at this chart all day and think about all of the periods in time in history that have impacted some of what's happened here. I'm not going to do that. I'm not going to subject you to that, but I think that this is a helpful reminder for all of us that things have changed quite a bit and changed quite a bit even in some of our lifetimes. And then the last point that I think is really important to emphasize here is that the inequities that we see in rural health are relatively new. I talk about them almost as if they're a given, and they're not a given. They really started to emerge in the early to mid 1980s, around the same time as the rural farm crisis in the 1980s. They were not solely caused by the farm crisis, although the economic conditions in the 80s contributed to the inequities that we still see today. This chart shows deaths per 100,000 people, and rural is the mustard color and urban is the dotted blue line there. You can see that they were on a similar course, and in many ways, it used to be pretty dangerous to live in urban places. Urban places had a bunch of public health challenges for much of our history as a country. That changed in recent decades, and now we see this gap continue to widen over time. So that's enough background. Now I want to tell you what we're doing at the University of Minnesota, knowing all of these challenges that we face, and also knowing the strengths that exist in rural communities. How are we building on those strengths, and how are we addressing those challenges? Here's one example. And again, there are many, many things happening across the university. There are incredible programs in all of our health sciences and health training programs that are happening. The University of Minnesota Extension is one of the best resources that we have, I think, personally, and so many more examples. But we at the University of Minnesota Rural Health Research Center have been doing work in rural health for about 3 decades now and have been really focused on unpacking policy and structural solutions to address some of the inequities I shared with you. The Rural Health Research Center includes many different components. It includes a Rural Health Research Center cooperative agreement with the Federal Office of Rural Health Policy. It includes the Flex Monitoring Team, which oversees the quality of rural critical access hospitals. And I'm going to walk us through each of these, so don't worry about memorizing them. It includes the fairly recent Rural Health Program, which I'll tell you a lot more about. I'm very excited about it. It includes the very recent Interdisciplinary Network on Rural Population Health and Aging, and several other rural-related projects. And I want to tell you about each of these because I'm excited about this work. I'm clearly biased, but I'm excited, and I hope you will be too. First, a funding acknowledgement. We get our funding for the Rural Health Research Center from a variety of sources. As I mentioned, we get some funding from the Federal Office of Rural Health Policy, but we also receive funding through the University of Minnesota Office of Academic and Clinical Affairs, the Clinical and Translational Science Institute, or CTSI, which is funded through NIH. the National Institute on Aging, and several other sources, including some foundations and private dollars. The Rural Health Research Center Cooperative Agreement that I mentioned was started in 1992, funded by the Federal Office of Rural Health Policy, which sits within the Health Resources and Services Administration within HHS. With this cooperative agreement, we work in cooperation with the federal office to decide on the research priorities and to publish and disseminate work. We do 4 projects a year. We have 4-year grant cycles, so we're doing 16 projects a grant cycle. We're busy. We're doing a lot of things all the time. The work that we do under this cooperative agreement is national in scope, so not specific to Minnesota, and it's really policy relevant, meant to inform the work of federal and state policymakers to make sure that they're using the best available science and evidence to make decisions about resources for rural places. The topics that we decide on for this research are informed by policymakers, by people invested in rural health, by the literature, and by an expert work group that we have made up of people who live in rural communities across the country. Our focus area has traditionally been on the quality of and access to care and social determinants of health across the lifespan, aging, maternity care, equity. Our current grant cycle is from 2024 to 2028. So we are in year 1 of our grant cycle right now. There are other Rural Health Research Center cooperative agreements funded across the country, and I named a couple of them when I was talking earlier, one at University of Iowa and one at University of North Carolina, but you can see that they're scattered throughout the country here, and we work very closely with these other rural health research centers. I consider them my close colleagues and people that I really look to for guidance on rural health issues. This is just a small smattering of what we've been working on this cooperative agreement in recent years, just to give you a flavor of the breadth of the work that we do. We are working now on looking at access to and quality of care for people with disabilities, services to support rural residents who are homebound, medical debt, which I'll talk about in a little bit, obstetric unit closures, I mentioned already, access to neonatal units, social isolation and loneliness in rural places, access to long-term care, preventing and addressing elder abuse, coverage and extent of PACE services. PACE is the program of all-inclusive care for the elderly. It's wraparound services for people who need extensive long-term services and supports. Postpartum morbidity and mortality, housing and transportation and other social drivers of health, ransomware attacks on rural hospitals, and aging in place. This is not an exhaustive list of the projects that we've done, but it gives you an example of how we focus on care and quality of life across the lifespan. At the Rural Health Research Center, we publish a variety of types of products. We publish peer-reviewed manuscripts. We are, after all, academics, and that's an important way to move science forward and ensure that our science is validated and reviewed by others with expertise in this area. But we don't only do that. We do a lot of public-facing products. We publish a lot of policy briefs, case studies, practical implications where we interview providers in rural communities about how they're seeing these issues play out, chart books, infographics, methodology briefs, things like that. Everything that we publish is reviewed by the federal office and then published by us. And typically available on our website, although I can say right now there are some communication pauses where you won't see everything there. I'm happy to help connect you with resources if you're interested, though. We're very focused on dissemination and public engagement and outreach in everything that we do. And so we do a lot of op-eds, blogs, letters, commentaries. We very frequently work with the media, national media, but also really put a priority on local media and media that's reaching rural residents, media that's meaningful for rural residents. We do a lot of engagement with policymakers and agency staffers. We do webinars, just like this one, We do a lot of podcast appearances. We publish an annual report summarizing all of our work, and we are active on social media, in particular LinkedIn, to try and disseminate our work. Now to just briefly, very quickly, I promise, talk about some of the other projects that I mentioned before I talk about the Rural Health Program, which I think will be the most exciting thing that I mentioned today. The Flex Monitoring Team is led by my colleague Megan Lahr, and this is a cooperative agreement, again, with the Federal Office of Rural Health Policy to provide evaluation of the program that provides support to the more than 1,300 critical access hospitals across the country. These hospitals have been around for a few decades now, or at least the criteria to allow them to become critical access hospitals has been around for that long. These are, generally speaking, hospitals that have 25 beds or fewer and exist in rural places that are otherwise not closely connected with another hospital and not particularly well served. And they allow for a different payment model to help these hospitals keep their doors open. These have been a lifeline for many rural communities to maintain access to care. We work with two other institutions to do this work and do multiple projects a year to really understand how things are working for critical access hospitals. If you're interested in that, you can go to the Flex website and see all of their products and all of the work that they've been doing. I mentioned the Interdisciplinary Network on Rural Population Health and Aging, or INERFA. This is a grant from the National Institute on Aging. I lead this grant, and we are just in year one of our 5-year grant cycle. This was previously held at Penn State, and I was excited to bring it over to the University of Minnesota. But I work closely with partners at other institutions. I have co-leads at 4 other institutions. The goal of this is to increase the network of researchers focused on rural aging. We support pilot grants, mentoring, education, dissemination, and events related to rural population health and aging. And then this is a very busy slide, but I just wanted to let you know that we're doing a lot of other things in case you're worried we're not doing enough at the Rural Health Research Center. We have 2 different grants and contracts right now focused specifically on maternal health, one looking at maternal health data to create a data repository and research on maternal health focused on financing, and one that's providing technical assistance and coaching to programs in 15 states that are focused on improving their maternal health. I also, for several years, have been involved in research funded through the CDC that looks at help-seeking strategies for farmers. Farmers tend to have poor mental health outcomes relative to people in other occupations, and we're trying to understand some of the structural barriers to mental health help-seeking for farmers. And then I'll talk about this one in a minute, so I'm not going to spend much time on it now, but I have been involved for a few years now on work on recruiting and retaining healthcare workforce in rural Minnesota specifically. So I will come back to that. But as promised, I want to spend a few minutes on the Rural Health Program. This is a program that I co-lead with my colleague, Katie Casamano. We kicked this off in 2020, which was a tricky year to kick anything off, but I think that it has grown and thrived, and I'm excited to share where we are with it now. This program is funded through the Office of Academic and Clinical Affairs and the CTSI with NIH funding, so a little bit of institutional funding and some federal funding for this program. Our imperative in the Rural Health Program is to really address rural health and rural health capacity in Minnesota specifically. So this is very different than some of our national work, and this is much more community engaged than some of the other work that we do. In this program, we have a Rural Health Policy Postdoctoral Fellowship program where we train postdoctoral fellows to become leaders in rural health research. We have had an incredible group of fellows, and we are in the process of recruiting our next cohort. It's really been an honor to train people to move on to careers in this work. And then we have a rural collective that provides a forum for networking and cooperation across the entire University of Minnesota system for people interested in rural issues. And finally, we have a community engaged policy training program called Project Reach, or Rural Experts Advancing Community Health. I'm going to talk a little more about the collective and Project Reach. The collective, as I said, is a forum for networking, learning, and collaboration across all 5 University of Minnesota campuses and extension. As of fall of this year, I'll be able to say all 6 University of Minnesota campuses because we have the new medical school opening in St. Cloud, and we'll be folding them into the collective too. This is open to any faculty or staff across the University of Minnesota in any discipline. They don't need to be in health sciences. They just need to have an interest in rural people and places. To date, we have more than 170 members and 31 affiliated member centers. We do a variety of programming, but our bread and butter is to hold in-person events twice a year. I'll be out in Wilmer in 2 weeks for our next in-person event, and virtual events twice a year. We are going to be hosting the Vice Provost for Public Engagement at our next virtual event. In both the in-person and virtual events, the idea is to learn more about the rural work that's happening at the University of Minnesota and to give people a chance to get to know one another. We also have a publicly available membership directory and a way for people to share updates and opportunities. And in case it's not self-evident, why I think this collective is so vitally important is that sometimes researchers or others become interested in rural areas, which is wonderful, but don't always know where to start. And I think that there's a real danger to going into a community and trying to establish relationships without working through the relationships or the leaders who are already present there. We also want to avoid any sort of extractive research or extractive work that's happening, and we want to make sure that we're strengthening the relationships that we have in rural communities. And so to do that, it's really important to be in conversation with people in Extension, where we have Extension presence in all 87 Minnesota counties. It's important to be in conversation together and in conversation not just on the Twin Cities campus, but with Crookston and with Morris and with Duluth and some of our campuses that are more rural facing. For all of our in-person events, we have only held them outside of the Twin Cities campus, and that's something that I'm very committed to keeping up. We hold them in University of Minnesota locations across the state, and there are locations across the state. And then Project Reach, I said I would come back to. This is a leadership training program that we have for rural Minnesotans. We lead people through a 1-year curriculum where they identify a local health problem or a local health issue that they want to impact. And then we provide training and support, mentorship, guidance, and technical assistance in research and data use, health policy, policy communication, and civic engagement. But we really rely on the participants in this program to bring their own lived experience and expertise and community knowledge into the program, to know what their specific community needs and where the resources are and where the relationships are, so that we're building on those, so that we're not swooping in and assuming that we know what's best, because we certainly don't. But these rural community members do. This map here shows where we've had Project Reach participants over the duration of the program. It's a cohort model, and we keep cohorts small, so we haven't had a huge number of people, but we're in process of recruiting our next cohort now and look forward to welcoming another 4 or 5 people into Project Reach. And I want to give you a spotlight of one of our participants to give you a sense of how this has gone for people who've participated. Ann Buzzy was in cohort 1 of Project Reach. She was in our inaugural cohort and was very patient with us as we figured out how to do this. I had the honor and privilege of being one of her 2 University of Minnesota learning partners. That's what we call the mentors who work with the participants. Anne wanted to focus on social isolation among rural older adults. She lives on the Iron Range in Hibbing and was really committed to finding ways to make sure that her peers, other retired older adults in her community like her, felt engaged and valued and seen and included and not isolated. She focused on improving digital access and literacy as the solution, and Anne, through her efforts in the program, was able to get new provisions in the Minnesota Library 5-year plan. She was also able to write and place op-eds in the Star Tribune and the Duluth News Tribune. She had a fact sheet that she put together on rural aging that was published by the Minnesota House and cited in materials by the Minnesota Senate. And then I am thrilled to share that Anne was awarded the 2023 Minnesota Rural Health Policy Award for the work that she'd done in the program. And at the 2024 State of the Union, she was the invited guest of Senator Klobuchar because of the work that she had done in Project Reach. She remains an inspiration to me and is doing incredible work still, and we're really proud to call her one of our cohort members. So finally, I'm going to briefly end the talk today so that we have time for discussion by sharing a couple of research spotlights, just a little bit, a little sampling of some of the work that we've done recently in rural health. I'll be talking about rural healthcare workforce and rural medical debt. So the rural healthcare workforce, I said I would come back to this. This is a collaboration between myself at the Rural Health Research Center in the School of Public Health and colleagues at the School of Social Work, the School of Medicine, and the Minnesota Department of Health. And with this, we are focusing on identifying factors associated with why healthcare providers choose to practice in rural and what might make more people want to practice in rural, knowing that we have shortages. I mentioned those HPSAs before, the health professional shortage areas, and I wanted to show you a map of those. The places that are really dark blue here, that dark navy blue, are the places where the whole county is a shortage area. And you can see that we have a lot of shortage areas in the country. Most of them are rural counties. You can see that even in Minnesota, we have several counties where the entire county is a health professional shortage area. This, again, from RHI Hub, I am a big fan and came back to it here to end my talk. But RHI Hub provides some useful information for us on healthcare workforce. This graph shows where there are physicians per 10,000 people in metro or urban counties and non-metro or rural counties. The takeaway point here is that metro counties, urban counties have way more physicians than rural counties. Metro counties are the light blue and rural are the dark blue. The top set of bars is all physicians, and then we see that broken out by MDs, DOs, and then primary care physicians specifically. In every group, but especially in MDs, we have an incredible disproportion when it comes to rural-urban distribution here. The same story is similar for nurses, but not exactly the same. We don't see a difference for LPNs, although there's a shortage of LPNs across the country. So rural and urban areas alike need more LPNs. We do see a difference between rural and urban areas for RNs. So knowing all of this, knowing that this is an issue nationally and an issue in Minnesota, we've used data from the Minnesota Department of Health from the licensure survey to understand what it is that compels people to practice in a rural area if they do practice in a rural area. This very busy slide here, which you don't need to read every word, I'll zoom in on it in just a second, it tells you the different factors that compelled people to practice in a rural area across different profession types. APRNs, those are advanced practice nurses, registered nurses, physician assistants, and physicians. And what we found is that across all groups, growing up in a rural area is really, really strongly associated with wanting to practice there. We knew this already. This wasn't a new insight, but it was useful to show that this remains true in Minnesota. And this tells us that investment in K-12 education and in higher education, technical college, four-year college opportunities is really, really important for rural kids, rural residents to make sure that they have those opportunities in their community and ways to come back to their community. But it's not just growing up in a rural community. We also found that rural providers said some of the reasons they wanted to practice in rural communities was because they loved having autonomy in their work. They loved having a broad scope of practice. So it's things about the job itself that were really enticing. I think we could do a better job telling a story of what it means to practice in rural areas and what's attractive about the job. And then we also found that loan forgiveness, some financial support, was helpful for people wanting to work in rural areas. We also have had the chance to do some qualitative work on choosing to practice in rural areas, where we've done focus groups and interviews of rural providers in Minnesota. And this is a paper that we published just a couple months ago. This is hot off the presses. And I want to lift up a few themes here. In this work, we found that a few issues were really salient for people when they decided where to practice. Again, we heard a lot about the autonomy and the job and the breadth of practice. People like having a broad scope of practice, seeing people of all ages and with all types of conditions. That's really appealing to a lot of providers. So they lifted those up as reasons that they'd chosen to practice where they do. They also lifted up loan forgiveness. So those confirmed what we'd found in the quantitative results. But we heard a couple of new things too. We heard about the importance of connection with patients, that they were there because they liked the relationships and they liked being able to see people across generations, work with whole families, really get to know their patients. That was very appealing to the people that we talked to. And we heard from some providers that the reason they chose to practice in rural was that they appreciated the racial and ethnic diversity in the communities that they were serving. I don't think this is a story that's widely told about rural places. I think it's a story that we could tell better. And I think it's why it's important to disrupt the narrative that rural places are homogenous. That they're not. And we have many rural communities in Minnesota that are very, very racially and ethnically diverse. And for some providers, that's really a selling point and very appealing to them. And finally, I will wind down by just sharing a few insights on the work that we've done on rural medical debt, and then we should have some time for discussion. This is a project that we did through our cooperative agreement, and we've also had ongoing policy engagement with the Minnesota Attorney General's office on legislation to address this issue. So medical debt is debt from unpaid medical bills, and this is sometimes in the form of unpaid or past due bills from healthcare providers, but it also might be money that people have transferred to other sources, credit cards, personal loans, family and friends needing to borrow money to pay for healthcare. We all know that healthcare can be expensive, and especially if people need emergency healthcare, it can be hard to afford it, and people sometimes need to think creatively about ways to finance their care. Medical debt is all too common in the US. We owe more than $220 billion in medical debt altogether, and 40% of all US adults have some form of medical debt. 14 million adults, 6% of all adults owe more than $1,000, and 15% of all households owe some medical debt. And the consequences of medical debt are really serious. It can impact your credit score, your risk of bankruptcy, loss of your home, difficulty accessing another provider or more health care. Can mean that people are skipping medication or treatment that they need, and that can lead to more emergency care. Can also mean that people have their wages garnished or that they have difficulty affording other necessities. They might experience eviction or foreclosure or have trouble paying to put food on their table. It also impacts the availability of health services if hospitals are seeing a lot of uncompensated care and have trouble keeping their doors open as a result. So here's what we found, and I'll run through this pretty quickly so we have time for discussion. But the point I want you to take away is that medical debt is all too common, but it's more common in rural areas, and it's most common in places with high concentrations of people of color and indigenous communities. This is using data from the Urban Institute just to look at places where people have medical debt in collections. That's kind of the most severe form of medical debt, or the most severe way that we can see it. And looking across all counties, we find that nearly 16% of people in rural counties have medical debt, and nearly 22% of rural counties with a majority community of color or indigenous community have medical debt. Some of the disparity in medical debt is explained by differences in household income. This chart shows the differences between rural and urban places in average household income. You can see that rural residents make nearly $20,000 less than urban residents. That means that if there's an emergent healthcare event that's expensive, it's that much harder for them to pay that off. This shows the share of people with medical debt in collections in rural counties across the country. The darker the color, the higher the share. Again, this is not randomly distributed, and we see pronounced issues in the Southeast and in other parts of the country. This is the map specifically looking at Minnesota and including both urban and rural counties. And you can see that we have differences in the share of people with medical debt and collections across our state, too. Some of the lowest rates are found in the Twin Cities metro area. The highest rate of all counties in Minnesota is in rural Roseau County in the northern part of the state. And then finally, the median amount of medical debt that we see across the country is also higher for rural residents than it is for urban. And it's highest for rural communities of color and indigenous communities, where people hold an average of $835 in medical debt. For many people, that's not an amount that's realistic to pay off. We, as I said, have done a lot of policy engagement and dissemination around this. And so if that's something you're interested in, you can look up a couple of op-eds that we've written in MinPost about rural medical debt. And then down in the bottom right, hot off the presses, there was a committee hearing at the Minnesota House this morning for the Medical Debt Reset Act. And the Reset Act would buy up quite a bit of medical debt from Minnesota residents and pay it off through the organization Undo Medical Debt. We worked with the state attorney general's office to help to craft this legislation to inform the passage or the development of this legislation, not the passage yet, and then wrote a letter providing some evidence and some of our research to provide to the House hearing this morning. I'm going to stop where I started, which is with my grandmother. This is the cemetery where she's buried in Mendota, Illinois. Many of my other family members are buried here too. I have roots that go back generations in this rural community. And I need to place myself back in those roots in all of the work that I do. And I think that it's important for all of us to place ourselves in our roots, whatever those might be, to think about how that informs what we do going forward. And I will stop there. I look forward to any questions or discussion that you might want to have.
Thank you so much. That was fascinating. And we have a lot of engagement on the topic. So I'm going to start with a question which incorporates several questions. I'm going to try to smash them all together because I think that they are related. So
Okay.
hang on here. Okay. Provider pipelines, how to
Yeah.
overcome the trouble recruiting not just specialists really, but also generalists to these communities. How can rural hospitals afford to pay specialist compensation, which is very, very expensive? And you have to pay that in order to get specialists to come there, or else they'll wind up in the cities because they need to earn a living too. Family physicians have a much lower salary than specialists, but it seems that compensation overall, reimbursement, I should say, to rural hospitals is grossly inadequate. Rural hospitals are expected to do so much with
Mhm.
so little. And more and more of the population in rural areas, as you noted, is insured by Medicaid or Medicare or not at all. Those
Mhm.
programs reimburse much less than private insurances do. And so rural hospitals just continually, year after year after year, are, I don't want to say falling apart, but really lacking money to do all the things that they're being asked to do. How can we fix that?
That is a big question. You weren't kidding. I'm gonna give a few thoughts for that, and if I don't adequately answer the question, you can ask some follow-ups here. Uh, but first of all, I want to come back to that point that I raised in our research findings, where the biggest predictor by far, it's not even close, but the biggest predictor of people choosing to practice in a rural area is that they grew up in a rural area. So starting there, starting with making sure that kids in K-12 education have exposure to health sciences in their classroom, that they understand that these are viable careers for them. And then making sure that our community and technical colleges are well supported and have programs that are available to the kids in their community who might want to graduate from high school and go right on to a program in their community is really important for helping to keep people in the community. But it's not all health professions are going to train at a community or vocational college, and not all people are going to stay in their community for ongoing education. That's not realistic. So we also need to make sure that there are opportunities for people who move away from rural communities to be able to come back eventually. And this is where I see some really exciting innovations. I mentioned the new med school in St. Cloud that's opening. This is a partnership between CentraCare and the University of Minnesota Medical School, and they are enrolling their first class to start in the fall. And in those admissions decisions, they prioritize students from a rural background because of the research showing that those students are more likely to want to stay and practice in rural areas. That for them, it's not all about the finances, it's about serving the community that they feel called to serve. And I think that that's a really exciting innovation here in Minnesota. And it's one that people across the country are going to be watching closely to see how it works. But it's not enough just to open up that med school and offer those opportunities. We also need to make sure that tuition is low cost for them so that they're not graduating with so many loans that they feel like they need to go to the highest salary to be able to pay off those loans. It's important that they're graduating and that their salary can feel reasonable to support the life that they want to have in the rural community that they sought out to serve in the first place. And so there are investments in scholarship, in funds to keep tuition low for those students. I think we could do more to make sure that tuition for our providers generally is lower. And I think that then we would see fewer people choosing those high salary specialties. The incentives are all off for students in health sciences where I would say universally people go into school to become healthcare providers because they care about the work and they care about people. And the economics just don't always add up. And so I think people sometimes make rational decisions to choose the higher salary careers, which disadvantages rural communities for all the reasons that you mentioned. We have also seen growth in rural residency programs, and including growth right here in Minnesota. We've had some new rural residency programs open up. Those are really exciting. So if someone trains in an urban area, there's still an opportunity for them to come back and do their residency in a rural area and perhaps fall in love with that type of practice. And so we need more opportunities like that. We don't yet have enough opportunities to meet the demand. Um, but I think that that's another exciting way to think about addressing this. And then in terms of the specialty care, can rural facilities pay specialists enough to keep them in rural facilities and not move back to urban facilities? I'm not sure they can. And I'm not sure, in some cases, yes. And there are places that are doing that. But without the population density, without enough patients to support a specialty practice, it's just not realistic. So this is where we need to think creatively and think differently. Perhaps someone has a practice where they spend a day a week in a rural community or they are traveling between rural communities. We can think about models like Project Echo, a hub and spoke model where you might have more urban-based specialists, but working with rural communities. And there's didactic education that happens, there's training, there's support and mentorship. I think there's also a lot of innovation happening in technology and telehealth. It's amazing that I got this far into our conversation before I mentioned telehealth. That's an important piece of the puzzle here. And that's where we've seen a lot of innovation around access to specialty care. There's also innovation around mobile units, bringing care to people, but perhaps it's not brick and mortar care that's there 24/7. Perhaps it's just there for some of the time that they need it. None of that is going to be enough to meet all of the need. We need to continue to think creatively. And I know that I have rural health research colleagues across the country who are thinking creatively, and I look forward to more solutions in this area. But those are just a few thoughts. Hopefully that started to get at the question.
Oh, absolutely. And I just wanted to remind our attendees it's Severe Weather Awareness Week. And so I know where I am that the sirens have just started going off and it is planned. This is not an actual event going on. It's a test. And so I just want to reassure anyone who might be listening that we are okay. Um, Along the lines of what we were just talking about, and this is regarding maternal mortality that you discussed,
Yeah.
do you feel that that increased maternal mortality in rural areas is because of the lack of OBGYNs in those areas? Because, hospitals can't afford the OBGYNs? Or is it something else? Maybe because people are aging, there's more people aging in those areas, and so less people delivering babies, actually having babies, and so less experience delivering babies. Is there a way to attribute this to something concrete?
There is, and there's not one villain here. There's a lot of things that are happening all together. So, a number of factors that I want to lift up. There are fewer OBGYNs in rural areas by far. It's not even close. And family practice providers play an outsized role in rural communities delivering babies, and they, by and large, provide really excellent, high quality maternal health care. And so a lot of people in rural areas will never see an OBGYN, and for them, that's okay. Obviously, that gets more complicated for high risk pregnancy situations. A lot of people in rural areas, because access to care is more limited, because insurance rates are lower, because transportation is a barrier, and childcare is a barrier, and paid time off work is less common in rural areas. A lot of people are not getting access to timely prenatal care, so that's part of it. People are having fewer prenatal visits. And then accessing that more intensive prenatal care is more challenging in rural communities. I know in Minnesota, we have a lot of people who need to travel, say, from Grand Marais down to Duluth. And traveling down Highway 61 is an entire day's adventure if it's during heavy tourist season or during the winter. That's not going to be feasible for everyone. If you don't have time off work, if you don't have childcare for your kids, you might just forego that care. So some of it is about healthcare. A lot of it is about all of those other social determinants of health that I mentioned. The people who are having babies in rural areas are more likely to live in poverty. A lot of people are food insecure in rural areas. Food access is a real challenge. I didn't mention that before, but it's a real challenge. People are maybe working in unstable jobs. People may be working in jobs that expose them to hazards that may be dangerous for a fetus. And then this has changed in very recent years, but teen pregnancy has been more common in rural areas too. People becoming pregnant at younger ages and becoming pregnant with various risk factors. Also, rural residents have higher rates of chronic conditions. I mentioned that in the beginning, and chronic conditions and comorbidities can really exacerbate risks of maternal mortality and infant mortality, unfortunately. It's a horrific situation and one that I'm glad that we're focusing a lot of research attention on. I have colleagues who are doing wonderful work in this area, and I think we need a lot more investment into it.
Um, I just wanted to also note one of our attendees pointed out that telemedicine services, I believe, are going to be eliminated from the Medicare payment program, according to recent news reports. And I know you just talked about how we could increase specialist contact with rural residents through the telehealth programs, but it sounds like that will most likely be going away.
Yeah, I
Yeah.
didn't talk a lot about what's happening at the federal level in this conversation, um, and partly because things are changing quickly, but it looms large in everything I said. Some of the changes and the cuts that we saw at HHS last week are only beginning to be understood and will have dramatic impacts on some of the issues that I talked about today. And some of the proposed cuts, I think will also have dramatic impacts. I'm concerned.
Yeah, thank you for addressing that. We've just had so many people ask that question. How will these changes affect not only some of the solutions you're talking about, but also the funding for your own organization and the grants that allow you to do the work that you do? Do you fear for that funding as well?
I do. I do. I think that our funding is less precarious than many of my colleagues at the School of Public Health, for better or worse. Rural health has bipartisan salience and bipartisan appeal, and I think that there are pieces of it that insulate us somewhat from the funding cuts. And yet, there are some topics that I think will be off the table for us to be able to research for a while. And there will be changes to the way that we are able to communicate our research that I think will have important impacts. There are also some changes that are still unfolding and that we're still understanding. I mentioned the farmer mental health project that I've been working on for many years. That's funded by NIOSH, the National Institute of Occupational Safety and Health, through the CDC. Last week, all of NIOSH was let go, and so we haven't had that grant terminated yet, but there's no one left to administer it, and I don't know. I don't know what's going to happen with that. It's a challenging time to be in public health and to be doing academic research in this space. But I retain a lot of hope that we'll continue to do a lot of the work that we're doing. And I think it's only going to become more important. I think if we see cuts, the issues that I talked about today are going to become more pronounced. And so I'm committed to this work, and I think it's going to be perhaps a bumpy few years as we figure out how to navigate it.
Well said. All right, here's a little bit of a lengthy question. I'm just going to read all of it. I think it's
Sure.
important. Are you aware of work to expand access to the Medicare hospice benefit? This attendee says there are limitations on who is able to be a hospice provider related to maintaining a certain census, and in certain rural areas, that requirement is never met, and therefore they can't apply to be a hospice provider. An easy fix seems to be allowing critical access hospitals to bill hospice services with maybe without regard to the minimum census. Maybe an
Mhm.
oversimplification. Long way of saying, are you aware of any initiatives trying to address the disparities for rural access to end-of-life care billed under the Medicare hospice benefit?
Oh, that's such a good question. I'm not going to have a good specific answer to it. I'm not aware of specific efforts to address that, but that doesn't mean that there aren't specific efforts. I would point that person toward the work of Stratus Health, which is one of our friends here in Minnesota. They do excellent work on healthcare and health policy and rural health, and they focus quite a bit on rural hospice care. And so it's possible that they have done some work to answer that specific question, and I just don't know off the top of my head. But it would be easy to look on the Stratus Health website and see if they have anything that gets at that. It's an excellent question, though, and now I want to know the answer to it. So if anyone else knows the answer, let me know.
All right. To what do you attribute that widening gap that you showed on a slide, showing the rural mortality penalty, the gap getting wider compared to urban mortality?
Oh, there are so many things to attribute it to. Our economics and occupations and industry have changed dramatically. I don't need to tell anyone here that, but they've changed dramatically in the past century, but even in recent decades. And some of that has impacted the overall economics of rural communities. That has meant a couple of things. It's meant that for some rural residents, they are continuing to work in occupations that expose them to hazards or that are dangerous in one way or the other. So there's some occupational exposure impact going on. It also means that there's a little bit of a selection effect here where to access higher education and to access certain careers, some people have moved out of rural communities, and the people who've remained behind are the people who have been not universally, but sometimes less well-resourced, less well-connected to um, jobs and economic resources that will insulate them from all of the health impacts that I talked about before. So I think it's really a combination of economics and demography, who it is that lives in rural communities. And then I think there's been just overt or not disinvestment from rural communities. So many of our policies are urban centric. So much of our research comes from urban places. I'm on the Twin Cities campus because that's where I'm able to do this type of work. The irony of that is not lost on me. We're really an urban centric country. And that has, in many ways, disinvested from rural communities in ways that have led to some of the health impacts that I showed you here. I have a colleague from the University of South Carolina who published a paper a few years ago that I assigned to my students. She coined the term structural urbanism to really look at this and look at the ways that because we distribute resources based on population so much, we advantage urban communities in many ways and disinvest in rural communities.
All right, we have a couple of attendees who've been interested in other innovative programs besides the fact that St. Cloud is opening up a medical school, which you mentioned.
Yeah.
Some of the thoughts here are, would there be a place for the Red Cross to
Mm.
have a place with the Collective and Project Reach program? And is there any thought to creating some sort of a transitional program for clinicians at the U who've been in the field to fast track to MD degrees?
Oh, interesting. Um, the Red Cross, absolutely. We'd be happy to partner with them. I could see a lot of opportunities for Project Reach members to work with them. I'm not particularly well connected with the Red Cross, and so if someone here is and wants to help me get connected, I'm happy to facilitate that. And then I don't know of programs to help fast track people to get their MDs. It, but I think it's an interesting idea. It reminds me of the MNGOT program where we're the Minnesota Grow Your Own Teachers program, sort of a similar philosophy, and I think worth thinking about. Surely someone in the med school is thinking about that, so that could be that there's work happening that I don't know about. The RPAP program does still exist, though. I think someone might have asked about that, and that's the rural physicians program that where people spend 2 years on the Twin Cities campus and 2 years on the Duluth campus. And so the St. Cloud program is not replacing that. It's just growing our capacity to train rural focused MDs. There's also really, really excellent work happening at the dental school, the nursing school, the veterinary school, the pharmacy school, all of my health sciences, health school counterparts in training people to practice in rural areas. So I want to lift up the work that they're doing. Each of them should give their own seminar so that they can share more about that.
I'm glad you just mentioned the rural physicians program. There were a few questions about whether that also existed or not. Um, So I don't have any more questions at the moment. I know we have one more minute. If someone has a really short question, they could put that into the Q&A quickly and we can get it in. Otherwise, since it is so close to 2 o'clock, I think that we can probably call it a day. Thank you so much, Professor Henning-Smith. Just fascinating topic. And great answers to these questions as much as anyone can answer them. Thank you to the audience, as always, for the interest and the questions. The OLLI program, thank you to our sponsor, University of Minnesota Alumni Association. And as I don't see any more questions coming in, I will close by saying, please join us next week when Dr. Matthew Wynn will be presenting on hearing issues across the lifespan. So thank you again to everyone, and I hope that you all have a good week, and I look forward to seeing you all next Thursday. Bye now.
Thanks so much.
Thank you.